Welcome to 26 Minutes with Dr. Warren Siegel on the ZorMed Show. I'm Dr. Warren Siegel, your host for today's insightful discussion. We're joined today by Dr. Renata Kuperman from South Brooklyn Health, and our focus today will be on HIV and AIDS. A warm welcome to you, Dr. Kuperman. I'm so delighted that you could be with us today.
Thank you so much.
So tell us a little bit about yourself.
All right, so I'm Renata. I was actually born and raised in Brooklyn and moved out to Staten Island where I currently reside. I'm married, I have a 3-year-old, and I have one on the way. So
Congratulations.
Thank you so much. She'll be here very soon. I've been practicing infectious diseases now for about 6 years. I went to medical school in Long Island, NYIT, College of Osteopathic Medicine, and I completed my residency training at Maimonides Medical Center here in Brooklyn. And I also did my fellowship in infectious disease at Maimonides as well.
So as an infectious disease expert,
Yes.
You trained in internal medicine and then decided to change careers. Explain that to me.
So the way it works is internal medicine is a great residency to get into because there's a lot of little outlets you can take within the field of internal medicine. So internal medicine encompasses a lot of specialties, and so during my residency I went through different fields of practice. I rotated through gastroenterology, cardiology. I went through different rotations, and I found that when I rotated through infectious disease a few times, I really loved it. I was very interested in it, the diseases, and the thing that appealed to me the most was that you can give somebody one little antibiotic and the next day they're up and talking and feeling better and their fevers are gone. It's better than just, going into surgery and doing this whole big thing and then they're coming out better. So I found like just a little pill makes them better. And also all the different myriad of treatments and diseases out there, not just in the United States, but all across the world that we see. I found that fascinating as well. And so I stuck with it.
So infectious diseases, when I think of infectious diseases, I think of all the stuff that kills people. We just came through a pandemic.
Yes.
You must have been very, very popular during the pandemic.
Yes.
I think of dengue, I think of cholera, I think of all these diseases that unfortunately people are dying from. Today we're talking about a very difficult subject. Difficult for me because I'm much older than you. I remember the day that this new disease started. It didn't even have a name in 1981 when I was a medical student.
Yeah.
We're talking about HIV. Can you explain what is HIV?
So HIV is what we know as human immunodeficiency virus. That's what HIV stands for. It's a virus that attacks the immune system. Specifically the cells that we have in our bodies that fight infection. And so because they infect those cells, our body is not adept to fight infection as well. And so we put our bodies under more stress to get even stronger, more scary infections. So initially, the first case in the United States was reported in 1981. At that time, it was a very, very scary disease to have because there were no treatments. People were just dying and nobody knew how to fix it. But then in 1981, we had the first drug that came out known as AZT.
1981?
I'm sorry, 1987.
87.
I'm sorry.
Right, yes. No, I remember.
Yes, 1981 was the first case, 1987 was the first drug, and it wasn't that effective, had a lot of side effects, but in 1997, the game changed for the virus. We came up with HAART, which is highly active antiretroviral therapy, which actually really have changed the prognosis of HIV. And so the virus, which we know of, is this virus is usually spread through bodily secretions, most commonly during unprotected sexual intercourse or through blood, so needle sharing or injection drug use. And for the most part, it was a virus that used to kill. Now, with the addition of heart therapy and people taking medication and early screening, it has become a virus that you live with, but you can suppress very well with the medication, and you can live a very normal, healthy life. And I usually tell my patients, when the time comes for your life to end, it doesn't end from HIV, it will end from something else, like heart attack, stroke, old age, but never from the virus if you take your medication.
That's really incredible when you think of that, and I think about where we've gone from the days where this disease was first described. Again, didn't even have a name.
Yep.
Didn't know what the virus looked like, couldn't see it under a microscope, wasn't sure how you got it, how you give it to someone. God knows we didn't know how to treat it.
Yep.
From 81 to 87, it seems like a really short period of time till we developed a drug that you said really wasn't that great.
Yeah.
And then we're at a different point today. But let's back up a little bit. How could someone tell if they have HIV?
Yeah, so I mean, the easiest answer I can give is it's a simple blood test. So you can go to your provider, you can go to a community outreach center, you can go to the nearest lab, urgent care, and say, hey, I want to get tested for HIV. The reason you may want to get tested for HIV is you had a risky sexual interaction with somebody you didn't know, or you were using drugs and you didn't know where you got the needle from, or you are a healthcare worker and you accidentally stabbed yourself with a needle of a patient that you didn't know if they have HIV. So any doubt in your mind, or just, hey, I'm young, I went out a couple of nights last week, I met some people, and we engaged in some sexual activity. I just want to check myself to make sure I'm okay. So the easiest way is just go to your nearest lab, go to your doctor, and ask for a blood test.
Really? So you just walk in and say, I want an HIV test?
That's it.
It's that simple?
It's that simple.
Now, I know babies are screened for HIV, right, at birth?
So generally the mothers are. During pregnancy, we make sure that the mothers are, HIV negative, and if they are positive, we make sure to see that they're on treatment, or if they're not, initiate treatment. If they are on treatment, babies are born without HIV.
So everybody in New York State who is pregnant in prenatal care automatically gets an HIV test?
Yes, the provider obviously will ask you and counsel you on, hey, I'm going to be testing you for HIV in pregnancy. Are you okay with that? And most mothers will say yes, please make sure.
So after they give birth, they now know they're HIV negative.
Yep.
That means their baby is HIV negative automatically, or is there still a chance that the baby will develop HIV?
No, there's really no chance if the mother is HIV negative. Let's say she was tested before, doesn't have any risky factors, is not on treatment, she's HIV negative, she'll have an HIV negative baby. If she is HIV positive, and she is routinely monitored by her OBGYN as well as an HIV provider to make sure she has an undetectable viral load throughout her whole pregnancy, her baby will be born without HIV. There's not a chance the baby will be born with HIV.
What about her partner during that prenatal time? Does her partner come in to get tested as well, do you know, or is that not really necessary because she's being treated?
Exactly. Yes.
Or tested.
Yes, I mean, unless there's some type of domestic abuse or violence or some kind of thought that there may be a chance that the partner could have HIV, but as long as the mother is negative, there's no way that the baby will be born positive.
You used the term a few minutes ago, I think you said viral load. Can you explain what that is?
Yes. So I'll tell you, I'll talk about two numbers. So whenever my patients come to clinic, there are two numbers that are very important with HIV. The first one, we'll talk about the viral load first. The viral load is the amount of virus, HIV, in a person's blood that is affected with HIV. So the higher that number is, the worse the viral load is, and the more virus is circulating through the system. The CD4 count are these fighter cells that all of us have. In somebody who does not have HIV, with a healthy immune system, that number usually ranges from 500 to 1600. That's normal. In patients with HIV, the CD4 counts tend to be lower because their immune system is lower, and so their body isn't as efficient at fighting infection. Once that CD4 number drops down to less than 200, that is where the word AIDS comes into play. That means that your immune system is badly damaged from the virus and you are at risk for getting other infections. So whenever I educate my patients, I tell them that your CD4 counts are like your soldiers. You want them as high as possible so that they can fight the enemy, which is the viral load, and bring that down. As long as your CD4 is up and your viral load is down, you are doing well, and the virus will not spread even higher and make your immune system weaker. The way that happens is by taking your medication, which we call heart therapy, every day, and not missing any doses. And if you do that every day for 6 months, like as if this is like the number one medication in your life and you need it like the air you breathe, once you hit 6 months of a viral load that's undetectable, meaning that it is lower than what lab you went to that detects like their level of detection. Some labs say less than 50, some labs say less than 40, some say less than 30. Whatever your lab uses, if you are below that level for 6 months, you are considered undetectable, and that is translated to untransmissible. So U equals U. And what that means is you can live a long, healthy life. You cannot transmit the virus to your partner, and you cannot transmit the virus during pregnancy, and you can be with a non-HIV person and not give them the virus.
Wow, sounds like a seesaw here.
Yep.
So let me see if I get this right. If I'm worried that I might have HIV
Mm-hmm.
because I did something that I regret,
Yeah.
whatever that is, I can go to any doctor,
Mm-hmm.
any healthcare provider,
Yep.
nurse practitioner, PA, and say, I want an HIV test, and it's a simple blood test?
Simple.
I've heard about things in the mouth and saliva tests. Are those worth
They
doing?
have home tests.
Uh-huh.
I preferably do not. They're good. They're okay, but blood is much better. It picks up the virus much quicker than the saliva.
Okay, so I go,
Yep.
I get a blood test,
Mhm.
and I'm HIV negative. I don't have to worry about it.
Yeah, so there's a little caveat. So
Okay.
there is a time period. We call it the window period of infection. It's the first 2 weeks. Let's say you had a sexual encounter last night. You go get tested tomorrow. You may test negative, but I always recommend my patients to test again in 2 weeks, because there's a 2-week mark where the virus may not replicate as quickly, and it may not pick up the viral load yet. So if you are very worried that there's a high risk exposure, I always would tell you to retest in 2 weeks. If that test is negative, then we're okay.
So after 2 tests, 2 weeks apart of being negative, I can stop worrying.
Yeah.
If I'm positive,
Mm-hmm.
do I need to see somebody like you, an infectious disease
Yes.
specialist, or do I go to an internist?
Yes.
What's the next step?
The next step is once you test positive, you will be coordinated to an HIV specialist. You will be provided care to somebody that specializes in HIV. The Department of Health usually, any positive HIV test, they will call you, let you know, and then they will, coordinate you into care so that you can start therapy immediately.
Oh, so how does the Department of Health get involved? So everybody's going to know my name, my social security number, my address, my phone number?
No, so it's very confidential. It's very confidential. That's the first thing they tell you when they call you, that you have tested positive. We will this is all confidential information, only you and us know, and that, you know, this information will not be shared with family, friends, or significant others. When they do, they will ask if you've been with any significant others, or if you have a significant other, and they will anonymously let them know. But it's not, they would not say, oh, this person gave you HIV.
We'll talk about that in a few minutes.
Yeah.
I'm assuming now, if I test positive, I need another blood test for this CD4 count and the viral load. And the viral load, I want it to be low, like my cholesterol, right?
Right,
Low.
yes.
And the CD4 I want high,
Yes.
like my income, right?
Yes, exactly.
So it's that seesaw.
Exactly.
And I can go on medication. Is this like an injection I have to be on? Is it pills that I have to be on? Do I have to take this forever?
Yes.
You mentioned once my viral load is negative, I can't give it to someone. I'm confused.
Yeah. So initially what happens is, well, you know, you get tested for HIV. Your screening test is positive, and then they do a confirmatory test. That's like the next step. The confirmatory test will let us know for sure if you have HIV.
Another blood test.
They don't make you go for another one. It kind of, the lab just automatically runs the second test. So you don't have to go for a second blood test. Once it's confirmed, then they refer you to an HIV provider, and then the HIV provider will then go ahead and do a slew of tests, blood tests, where they will get the CD4 count, viral load. That will help me and other HIV providers see kind of where we're at in the course of your infection. I will see, you know, if your CD4 count is low, below 200, we know you have AIDS. If it's above 200, we know it's HIV. It hasn't gotten to the point of this, serious illness yet. And immediately, we start you on HAART therapy, which is a pill. This is a little, I'm not gonna dive into it, but in 2021, they approved an injectable medication. That you do an injection once every 2 months. So that's the newest kind of finding on the horizon. But most of the time, it's a pill that has 3 components, 3 different medications in the one pill. So, when HAART was initially introduced in 97, 3-pill combo, people were taking 2-3 pills at a time, which was really hard on them, their bellies, and just, being compliant with the medication. Here it's one pill. It has all 3 formulations within it, and the patients take it 1 time a day, at the same time every day, and that's it.
One pill.
One pill.
Every day.
Mm-hmm.
Because I'm HIV positive.
Because I'm HIV.
And that will keep my viral load down. And my CD4 count up.
Yep.
Wow, come a long way since
1981
1981 to 1987, and then 10 years later.
Mm-hmm.
Wow.
Yeah.
Now, you made the distinction, I want to make sure I understand this, between being HIV positive and having AIDS. Can you talk a little bit more about that?
Yes. So when you're, we'll talk about kind of the symptoms. We'll jump to that point. Basically, after contracting the virus, in the first 2 to 4 weeks after, you're in the first stage of your illness, right? That is HIV. You will, 2/3 of people have flu-like symptoms. They have feverish, chills, myalgia, muscle aches and pains. They could have lymph nodes throughout their body that they feel, rashes, mouth ulcers. They just generally feel unwell. The other 1/3 may have no symptoms at all, okay? These symptoms could go on for a few days, could go on for several weeks. And then after that, it kind of levels off, and some people don't even get checked. They might think, oh, I just had a flu, or I caught something from my kid.
Wow.
Yep.
So 2/3 of people feel like they have the flu or COVID.
Yep, or
right?
COVID, or yep.
And may not even go for an HIV test.
May not even go for an HIV test. They'll just say, oh, I was sick, I picked up something, but now I feel better.
And 1/3 have absolutely no symptoms at all.
None. Yep.
So should just everybody be tested every year?
Well, so the general recommendation is if you engage in risky behavior, or you're in a younger age group, you should get tested every year
Okay,
or
so
earlier.
tell me, everybody's younger than me.
Yeah.
So tell me, what are the groups that we should be worried about? For the people, for the audience who's sitting at home,
Yeah.
who should be worried that maybe they should go have an HIV test?
Right. So, first what I mentioned is if you are sexually active with multiple sexual partners, you should definitely test.
And what does multiple mean?
More than one, right? So, and especially if you're engaging in unprotected sex, but also not just vaginal and anal intercourse, oral sex, anything that communicates the genital area with a mucous membrane, which is your mouth, your vaginal area, your rectal area. If there's any communication with the mucous membrane and the genital area, and there's a break in the skin, meaning that there's blood there, you are at risk of contracting the virus. So that's why people that, the gay population, bisexual, and any men who have sex with men, transgender women who have sex with men, anal intercourse is actually the highest risk of transmitting HIV because there is mucous membrane contact. There may be bleeding, and so anytime blood is involved, the risk of transmitting HIV is much higher. So if that's one of the risk groups. The other one is injection drug use, needle sharing. So if you should definitely get tested if you do that. The other thing is there are certain communities where there's a higher prevalence of HIV, depending on the locations that people live. If you are in that type of community where the prevalence is higher, they recommend to get tested. The other is...
Wait, can you explain that to me? My zip code?
Yeah. So
really?
It depends. It really depends on the area that you're living. There are certain areas with different ethnicities. We do see that in the United States, the Black African American community, as well as Hispanics and Latinos, they have a higher risk of contracting HIV. That's just the statistics. So if you're in a community that is heavily populated there, if there's a community that has more injection drug use or needle sharing, or more of the subpopulations of gay or bisexual or men who have sex with men, if there's a higher prevalence of that in the community with more sexual interactions, then yes, these would be the groups that I would recommend more testing.
And I would assume that those are also the groups that are less likely to get tested.
Yes.
Is that true?
Yes.
And what about access to medications? I would imagine this has got to be very difficult and expensive. What about for somebody who wants an HIV test but just can't afford it or doesn't have insurance? What should those people do? So
we actually, depending on the area that they live in, for example, at our hospital, we have a lot of benefits for patients that don't have insurance or can't pay for it. We actually offer them free testing, and the medications are covered under a government-funded program, so they never have to worry about paying for their medications. And the importance of that is because we know how devastating this disease can be and what it can lead to ultimately, which is AIDS, which we talked about, which is the late stage of the infection. And if you are untreated and you have AIDS, then your life expectancy is about 3 years. And if you have AIDS and are untreated and you get another infection on top of that, which we call opportunistic infection, your life expectancy drops to a year. So we know this, and we help everybody here in New York City, New York State, with access to care, testing, and medication.
So it sounds to me like this has become really a chronic disease. It's a treatable disease. Again, I go back to the 1981 when I was a medical student, when this was a devastating disease that basically, I'd rather be told that I had cancer than be told I had AIDS. The stigma was just so huge. Is that still an issue today?
So A lot of my patients, they still feel very embarrassed, and there is still this stigma about it, but I try to explain to them that it's not how it used to be in 1981 when we first heard about it. It's not transmitted by ways that we thought. I have patients come saying, "Oh, I don't even kiss my grandkids because I'm afraid I'm going to give them the virus." And one of my major kind of jobs is to educate them on, you can't transmit the virus if you're on medications. You can kiss your kids, you can hug your kids, you can eat from the same spoon and drink from the same drink, and you won't give them the virus. The stigma is much less than it was, if not almost completely gone. I think it's just more of what it used to be, and the fear of what it used to be, and just the lack of education of what it now is, and how much better the treatment options are, and the life expectancy, and just overall quality of life in these patients.
You make it sound so easy. But clearly doctors like you, nurse practitioners, PAs, have worked for years and years to bring us to where we are.
Yeah.
And I want to thank you for what you do every single day.
Thank you.
Thank you for continuing to educate all of us. It was such an honor and a pleasure to have you on the show today.
Well, thank you so much.
And that brings us to the end of our program today. We sincerely thank you for tuning in and learning alongside all of us. For more information about our show, please don't hesitate to contact us at 718-510-2103 or visit us online at www.zormed.com. Stay updated, stay engaged with South Brooklyn Health by visiting our website at www.nychealthandhospitals.org/South Brooklyn Health. This broadcast was proudly brought to you by Brick Media in partnership with South Brooklyn Health. Until we meet again, thank you, stay informed, and be well.